Second installment of our documentation series. Today, we're going to be tackling the biopsychosocial assessment, which we all know and love, but from one end of the spectrum or another. So we are going to be diving in and kind of looking at the biopsychosocial from a perspective of what is the purpose of it and how do we really make the most out of the time that we're spending, while also ensuring that we're not just kind of going through this rote documentation, like checking all the boxes, because what we really want to do within the assessment is make sure that we are really getting what we need in order to transition into that treatment planning and sessions. So I thank you all so much for letting me know where you're coming from. Some of you have added your specialty, children, adolescents. I see intake. I see interns. I love to see it. Criminal justice, harm reduction. I know it's Harm Reduction Awareness Month. So thank you for the work that you are doing. Amazing. Okay, well, we will get started because we have quite a lot packed into today's hour. My name is Kaylee Cron. I am a licensed master social worker and a certified grief counselor through the American Institute for Healthcare Professionals. I spent much of my clinical career working in grief counseling. It is a huge part of my heart and the biggest honor of my life. And I have kind of taken that work and now get to speak with you all and kind of share what I learned through that clinical journey. And I'm thrilled to do so. And excitingly, also the co-host of the I Can Notes podcast soon to come. I think we're looking at potentially March. So keep an eye out for an announcement email, I'm sure, coming to you. So today we will get started with just our learning objectives. We want to, of course, understand the structure and the purpose of the biopsychosocial assessment. Whether we know and love it or we dread it every single time, it is so necessary, and it can really be used as a powerful tool to more deeply understand your client's history and where you go from there. We want to also learn effective questioning techniques and gather meaningful information from our clients, and then explore best practices, of course, and how we integrate those findings from the biopsychosocial document as well as the interview to really build out a treatment plan that is unique and will really meet our clients' needs. So why do we even do this? That's a good question. Why they matter? I mean, what we're really trying to see here is a full 360 picture of our client. If you are a clinician that sees clients all day, every day, you know that there's so much information that you're trying to gather. When you're being intentional within that clinical setting, you want to know as much as possible about your client, because one size of treatment, one treatment plan strategy, one goal, all of those things, they don't fit everybody. And so if we're looking through the lens of, I know where you're coming from, I know your family history, I know things that you've tried before, I know things that you've struggled before, it really gives us a better framework with which to build that treatment plan and that ongoing treatment so that we're really supportive. And again, not just checking those boxes. We want to look at the whole person, not just what they're bringing to a session. I also see the biopsychosocial assessment time as a time to really dig deep. Of course, there is a document to fill out with all the check boxes and everything that gets you a lot of really good information historically. But it also gives you time to dig deeper, to build relationship, to double click on the things that you are kind of noticing will help build your treatment plan and are really like rising to the surface in regard to relevance within the treatment framework that you're working with today. I like to look at the biopsychosocial, those two elements. We have the document that they just fill out when you send it to them, which is like, check all these boxes of your family history, check all these boxes of what medications you're on and what your history is, all of that. So helpful. Think about that as like when you're drawing a picture, the outline, right? So the black lines that you are drawing this beautiful visual of who your client is. And then when you're in session, you reviewed that document, you kind of know where you want to take it, you kind of know what more information you need. You use that conversation time to color. use all the colors in your box and you find this really vivid picture of this person. So we need the lines, and the color really helps bring that personalized experience to life. Of course, we also need to use the biopsychosocial for insurance, justifying treatment, our documentation, and when we're collaborating with an interdisciplinary team, they need that information too. They're not going to be gathering necessarily all the same depth of conversational information, but you're going to be able to take that through your documentation and tell a story that is relevant to the entire team. So, digging into the details of the biopsychosocial, we have three core components. So the first we tackle is biological. This is when you're looking at the assessment that you kind of send out to your client. And if you're looking for one of those, we do have it on our handout tab. It's the intake form. In our last session training where we talked about intake, I showed that we send that to the client, and you'll also see that in the video today. And the client fills out this form, and so it's really nice to have. It is highly comprehensive. So if you're looking for something that really digs deep in each of the areas, please download that and make sure that you're utilizing a really great tool. But the biological is a lot of check boxes. We want to know medical history. Do you have conditions, medications, genetic predispositions that are going to inform how we're working together? Additionally, is there a history of substance use? How often? Because substance use has biological implications of like, how is that impacting neurologically and how you're showing up to sessions. There are some situations where if a client is actively using substances, that might be an area where it's like, well, time to refer out. That's good information to know, to say you need to get to care elsewhere because that's not what my specialty is, right? And then we also have neurological considerations. You want to think about history of traumatic brain injuries. What is their cognitive functioning? What's the baseline with which they're able to participate in therapy? Then we also have our psychological factors. So that is psychologically, where are we starting from? Cognitive patterns. How do they think? How do they process through information? What does their self-talk look like? Kind of like setting a framework for potentially goals that you're setting within your treatment plan of like, hey, we're working on grief. It sounds like you have a lot of really negative self-talk or potential suicidal ideation. And I want to flag that. And those might be areas you want to dig deeper during the conversation. And then we have emotional regulation. Again, what are their coping mechanisms, mood history? Typically when we're going through an event that would cause us to come to therapy or counseling, those coping mechanisms or how they typically react to situations gets louder, gets more magnified. And so it gives us a chance to really zoom into, is this helpful or hurtful? Is this going to get us back to a baseline so that we can start to build some better skills that are more helpful to you? Or is that something we really need to dig into? And then again, looking at trauma history, what are their adverse experiences? It is really important to look at how a history of trauma painted or colored their view of the world moving forward, so we can kind of gather that information as well. Social factors. So this I like to think of as there are definitely boxes within the handout, but this is where I really spend a lot of time because this is the storytelling piece. I feel like when you are getting to know your client the most, these are the areas that you're going to want to dig into depending on what they're coming in to see you for, to really understand what are their social relationships look like? What is their support system? Family dynamics, friendships, community ties. How do they take their personal experience? Who is around them at those times? And who are their supports? Who are helpful people? Who are unhelpful people? So you can really sift through and help within the treatment planning process, of course, because we need social support. So having an understanding of what that looks like and what's important to them, who's important to them. Socioeconomic stressors are also going to be incredibly informative as you journey through supporting your client. we need to know, when we look at the Maslow's hierarchy of needs, that baseline safety, shelter, food, do they have those things met? Because if not, how are we going to be working on something higher up on that pyramid, like grief work? Like, how are we really digging into that if you are hungry, if you don't have a roof over your head? So those things are really informative, because as a clinician, you want to make sure that basic needs are met so that then they can start to travel up that hierarchy, right? And then, of course, we always want to look at cultural and identity influences. What is the intersectionality that they're bringing? Every single one of us, regardless of where we come from, who we are, brings with us a viewpoint of the world that is incredibly unique. And it is painted through our cultural experiences, the identities that we hold, how we're treated in this world. All of that becomes a framework under which we kind of function. And in the absence of understanding the cultural impacts of what your client goes through on a daily basis, we really are kind of working in a vacuum there. So being able to expand that scope and understand we're not just working with grief here. We're looking at culturally, how do you and your how does your culture look at grief? Because it's different from one culture to the next. It's not just mine. Mine isn't the one that matters. It's my clients. When we're looking at times when we're working with clients with depression or anxiety, what kind of discrimination have they experienced that kind of added to or exacerbated those issues? And then, of course, there's spiritual beliefs. Whether or not you hold any strong spiritual beliefs, again, doesn't matter. How are they viewing the world, and under which lens are they viewing it? Because that's going to help, again, inform as you're treatment planning and thinking through how can we support this client after they're done with me? So what it really comes down to is asking the right questions. And I think what I always go back to, like, yes, we have a list of things we have to know. And we have a plan kind of going into the biopsychosocial, like, all right, they're coming in for grief. I really do need to know more about this. So within the framework of the biopsychosocial, what things am I going to dig a little deeper into? But your client also knows that like whether or not you're being genuine. And I think that's something that within the framework of the grief work that I have done, I always function with this one basic tenet, which is compassionate curiosity. So when we're navigating through this biopsychosocial assessment, we're not just asking questions to get answers to be able to document and to be able to do the treatment plan. That is one line of what we're doing. But we're also working to build rapport with our client. We're also seeking to understand them a little bit better and a little bit deeper. And without a genuine desire or interest in their story, you're going to miss things. So what I always start with a baseline of compassionate curiosity of I'm asking you these questions because I'm curious. I want to know, I want to dig deeper. You're going to pay attention to things more because you're compassionately curious. You want to, you mentioned this thing, and I want to know more about that thing because I care about how it fits within this entire framework. So we want to make sure we're asking open-ended questions. So it's not just a yes, no. Like, can you imagine sitting in a session where all of the questions are just yes and no, and there just isn't much to it, and you won't ever get all that much color on your paper. We also want to avoid leading or assumptive questions. So, of course, we have kind of a strategy for within the social element. We want to learn a little bit more. I always like to be really transparent about why I'm asking deeper questions in different areas, because I don't want to feel cagey, and I don't want my client to feel cagey. I want to say, like, hey, we're going to be talking about social supports within the framework of grief and how we can build a treatment plan from that. Tell me about how you feel supported in your world. What people do you see? Who do you spend time with? Who do you lean on in hard times? And that will kind of open up more conversation versus, just again, checking those boxes and them not really knowing why you're asking. We also don't want to lead with assumptive questions. I think all social workers, all clinicians are told when we're trained, leave yourself at the door. When we bring assumptive questions into a session, it's like because we're bringing ourselves and like how we're viewing the world and like the the framework with which we bring our expertise. We may assume something and travel down a road that is not helpful, and it doesn't actually help our client. And so kind of traveling in the wrong direction. So whenever possible, ask the questions you need to ask, dig deeper in the areas you need to, while also allowing the client to lead. Because the more they're leading, the safer they feel, the deeper they're going to go. I also want to, always make sure a client feels safe, comfortable, within the framework of grief. And I know this with so many different areas of focus is that we're not talking about happy, fun things. They're coming to counseling or therapy because they're dealing with some really dark stuff. And and to make sure that they feel like of all the places you're going to talk about it, this is the place. Let's get deep. Let's do this. I don't judge you. You are under HIPAA. You are protected here. And making sure that they know that, like, of all the places they could share this information, you are safe. Because again, that safety is going to allow them to dig deeper, to say things out loud that they perhaps never would ever say out loud to a family member or a friend because they don't want to scare them. We also want to focus questions on the portions of the form that you need more depth. So again, like in my professional time, like the psycho and social are like a lot of storytelling, and you can add a lot of color in that area. The bio, of course, like depending on if you are a substance abuse counselor, that in the bio area, you would dig a little bit deeper within that history of substance abuse and kind of where that comes from. But I think that always still leads to the social and the psycho portions. These are just a couple example questions to allow you to kind of have a couple options, making sure that you're not kind of having standard questions that you're always asking, but these are based on compassionate curiosity. Who in your life do you turn to for support? What are some ways you typically cope with stress? Like really wanting to know the answers to these questions rather than just checking a box. So, more than anything, um, I think within the clinical framework, there are things that we have to do for insurance coverage to make sure that we're able to fill out all of our forms and our documentation properly. But above all of that, your client is coming to you as a human being who is having a unique experience that they are struggling with. And their story and how they choose to tell that story is the most important thing happening in that room, no matter what. The form that they fill out is a guide. Their narrative, what they share with you, how they go deeper, and how much they trust you within that depth, that is what's important. And as a clinician, you have this clinical framework in the back of your mind that you are pulling in, that you're able to flag things that can check your boxes, of course, but they also give you information on where to dig a little deeper because as the clinician, you are bringing that special set of skills. They don't necessarily know that they're sharing those like perfect points with you, but that's kind of what's going on is they are opening their heart to you. And it is really important to honor that, which is why in our last session, training. If you were not here, please watch it. I believe it is recorded and it is available. But it talks about making sure that you're finding the right fit client prior to this huge heart time that they are giving you. We want to make sure that your client is a right fit for you so that they are not going from clinician to clinician to clinician, telling their whole story, telling all about their heart and soul. Because if you've ever been to therapy, that is fatiguing. That is exhausting. And you can only tell your story to so many people and be told this isn't the right place for you before you give up. And we don't want them to give up. So a gift we can give is making sure they're in the right spot before this biopsychosocial happens. We also within the framework of the storytelling component. We want our client to feel like we are just having a conversation. I'm compassionately curious. But again, your little clinician brain is always going to be going off and taking note of not just what is said, but how it is said, their tone, their body language, hesitations that they show within the conversation, the patterns under which they respond. You are bringing an incredibly vibrant collection of skills that clients don't have. First and foremost, distance from the issue, right? But also our clinical background and our knowledge of like systems and within like depression, grief, anxiety, all of those things. Like, how do those work together? And how are you being impacted personally? So we have a couple best practices for documentation, of course. The first thing we always want to make sure is that we are balancing the detail that we need to provide in order to have things covered, in order to document accurately and adequately to tell the story of what happened in that session, and what you're working on. But you also want to be concise because there is sometimes too much information given within documentation to where if you're audited, I've had clients, who are going through divorce hearings and they bring their kids in for counseling or they come in and talk about, the grief that they're going through. Those documents get audited. And how much information am I giving about that person's ability to parent, which is totally outside the scope of what I'm documenting on, right? And so it kind of like always be mindful of, if eyes were on this thing, on this documentation, am I giving enough information for clarity without giving so much information that doesn't necessarily apply to this like laser focus of what did we talk about, what did we work on, what are our goals, etc. Also using objective and not assumptive language. And then just making sure that your documentation aligns with treatment goals. What's really nice about ICA notes is that all of that kind of lives in the same place. And so we'll watch a documentation, the documentation portion after the interview portion, and that'll kind of show you how that lays out to like really let you take what are you supposed to be working on to what are you documenting about your visit today. So examples of the objective versus assumptive language is, client has poor coping skills. That is not objective, right? Like that is, I'm making a judgment about my client, which may or may not be accurate, but it also doesn't really paint a picture of what was talked about. Like, tell me more about that. Like if I was your therapist and you were showing me your documents, I say, tell me more, explain deeper. So you would say client reports feeling overwhelmed and currently lacks structure for coping strategies. So that in and of itself within that document can also lay out goals for a treatment plan. So we have a couple common challenges when it comes to documentation, specifically within the biopsychosocial assessment. First being a client who is withholding information. If you work with children and adolescents, I think I saw a couple of you mention that in the chat, that's where you're coming from. There may be times where your client does not divulge everything to you. And that is true across the board of age. But when I think about the clients that withheld the most information from me, it was teens. And why is that? And we think about, again, going back to that conversation about compassionate curiosity and building rapport. And do they feel safe? So if a client is withholding information, the question is why? And within our conversations and our back and forth and our rapport building, can we get the information that we need through that relationship? Like, can we build a reality where they feel safe enough to come to me and share the information that is really needed in order to move forward? If not, what else might be going on? There may be a general lack of safety elsewhere. So that's something to think about of if you are pretty aware that information is not being divulged, kind of flagging that and wondering like, okay, relationship building perhaps. We also have time constraints in a busy setting. When you are working through a biopsychosocial and I know this is hard in the clinical setting, and in an ideal world, we can all do this, but we want to be really mindful of how much time we're devoting to each client, because what's happening kind of within every session is we're starting pretty surface, right? We're up here having a conversation, we're building rapport, we're hanging out, and then we get into the conversation about what brings them in, their family history, their social stuff, like everything that's going on, the stories that they're sharing with you, and the dark stuff is really deep. That's hard stuff to navigate, and there are times when more time has to be set aside for that portion, which makes it a little difficult to spend time coming back up. But we want to be mindful of that. So, as the clinician, making sure that you're remembering you have time. You're going to keep seeing this client. You need enough information to create a treatment plan, to be able to document the biopsychosocial without going deep into every single story, because you frankly don't have time, and there's going to be time for that. So making sure that you're really structuring your visits. In an ideal world, you could spend as much time with the client as you want. We don't live in an ideal world, and I think that goes without saying. We also have the issue of unintentional biases that we always want to be aware of. And we talked about this in the last session as well. If you have certain communities that you cannot reasonably come in objectively to work with, that is something that you need to know about yourself as a clinician and work through before you have a client in your session that you cannot be objective with, that you cannot leave yourself at the door, that you cannot set your own biases down. Those biases can, if unknown, shape how you view your client and what goals you're going to set with them that are more for you than for them. So it's very, very important to be aware of that ahead of time. And again, address that at the beginning before they get into their story as much as possible. Okay. So this kind of teeters on today's conversation as well as next time's conversation. So how are we integrating our assessment into treatment planning? So we're, of course, going to use the data that we pull to inform the interventions that are going to come through within the treatment plan. We want to connect client strengths to the recovery strategies that we're building out for them. And then we also want to make sure that the treatment planning process, as it spills over from the biopsychosocial, feels incredibly collaborative. Because if a client is not on board, they're not going to be bought into the strategies just because you told them they're the right ones. So making sure that you're bringing your client along within that treatment plan. So now we're going to dive into the video vignette of a client session, and then we will then follow it up with a documentation demo of that session. Hi, Jenny. How are you doing?
Hi, Keely. I'm doing well. How are you doing today?
I'm good. It's so good to see you.
Yeah, it's good to see you again.
I was really excited to see your packet filled out and an appointment on my schedule this morning. And so I just want to let you know I got the biopsychosocial that you filled out and the other assessment forms that I asked for. So thank you so much for that. I know it's really time consuming and a little tedious to fill out a complete family history.
Yeah, there were a lot of forms, but that was okay.
Yeah. Well, it's hopefully letting us check more boxes so we don't have to waste our time in here doing that. But within those documents, you also received our HIPAA to just make sure you know that everything we talk about within these sessions is completely between the two of us, aside from any comments, serious comments around hurting yourself or somebody else.
Yeah.
With that in mind, are you comfortable moving forward today?
I am.
Amazing. Well, I want to get started just giving you kind of an overview of what we're doing today.
Okay.
We are completing kind of the first big section of our work together, which is a biopsychosocial assessment, which feels like a, what is that? And so really when we break it down, we are looking at biological, psychological, and social factors that kind of build a complete picture of you and how you are navigating this current situation that you're bringing to counseling today.
Okay, great.
So within the framework of that, just wanting to let you know that I know a lot about you based on the forms that you filled out. But I don't want us to just rely on that. So I want you to think of these two components that we did. So the paperwork you filled out ahead of time is you drawing the picture for me. Very basic. And then within this call, we're going to color that picture in together. So we have a better, more dynamic picture of Jenny and what brings you into counseling and how we can move forward within the treatment plan.
Okay, sounds good.
Okay, awesome. Well, just to get started, it may feel like I'm asking questions that you already answered, but it's mainly because based on what you're coming in with, I have a certain set of questions that I want to make sure I have a lot of information on, so that we can get a little bit deeper within the framework of coloring in those lines, so that we can have a really good picture moving forward.
Okay.
So can you start by just giving me a little bit of a history of any kind of mental health diagnoses that you have?
I have been diagnosed with anxiety, so I am taking a medication for that that was prescribed by my doctor.
Okay. And are you currently seeing your doctor to just manage that medication and how you're feeling on it and making sure it's working for you?
I am, yes.
Okay. Incredible. Incredible. So you have been diagnosed with anxiety. How long has that diagnosis been in place for you?
I think I was diagnosed 3 years ago for that.
Okay. And then even zooming back further, family history of anything related to anxiety, depression, PTSD that may interact with grief here.
No, nothing's formally diagnosed. Just probably some ADHD on both sides, most likely, but that's about it.
I know we often have diagnoses in our head, but formal diagnosis is a different thing,
Yeah,
right?
nothing formal.
Okay, perfect. Well, just going off of that conversation around your family, I often say that we learn what grief looks like when we look to adults when we're little and they show us their grief. And so it kind of gives us a blueprint for what it's supposed to look like, being a major quotation point. When you think back to losses within your family that happened, how did your family typically react to those losses?
My first reaction is not great. I'm not sure what great looks like, to be fair. But my most recent loss was that of my grandmother. Lost her actually December of 2019. So right before the pandemic happened. So of course our family was prevented from kind of grieving together and a lot of the grief process that we had planned. So that was difficult, but for so many other reasons besides the fact that our family doesn't really discuss grief together. There's a lot of kind of avoiding and pretending it's not happening and trying to just move on rather than sit in those moments and process. So,
Yeah. And that's something you kind of have noticed with difficult things that have occurred in your family.
I have. The other time I can think of is my paternal grandmother died when I was 5. So a lot of memories, of course, are very skewed from 30 years ago. But it was a sudden loss for my dad. He didn't know that she was sick. And so the whole family, again, pretended that nothing was wrong. And suddenly there was a loss. And no one really knew how to react to it. And because my parents didn't know how to react, they didn't know how to teach me how to react. So, yeah.
Yeah. So when you think of like not reacting, did it seem like it didn't happen?
It felt as if, because my paternal grandmother, that side of the family lives on the other side of the country, or lived on the other side of the country. So we weren't able to attend any funerals or memorials. So we didn't get to go through a lot of those processes of grieving. Because they were so far away, we didn't have a very close relationship with them as well. So there wasn't a lot of there weren't the grieving markers, and then there weren't opportunities to suddenly experience the lack of this person as well. So it was almost like this person that existed, and then suddenly they didn't exist. And because of so few memories, I didn't even have an opportunity to grieve like I'd wanted to. So yeah, kind of hard to elaborate on those.
Yeah. Yeah. It's interesting because they're two very different situations, different version of Jenny, different relationship with grandparents, distance, proximity, and then what was going on in the world. But really pulling that back and saying, and we still didn't address it, even when she was right here. And it was almost as if the pandemic kind of catered to the glossing over of.
A little bit. Yeah. It kind of forced it to be a very similar experience as the first loss.
Yeah. And when you think about that kind of glossing over and not really like digging into that grief, do you see that spilling over into how you typically address major changes or losses within your current life?
Possibly. When I experience changes, it can be a little upsetting. I like things the way that they are. Also, probably some undiagnosed ADHD and anxiety there, of course. I like to know what to expect. And so when things change, especially when I don't expect them to, it can kind of just throw me. So it probably takes me a little while to catch up to life, to catch up to what's going on and feel like I have control again. That lack of control, that can be really unsettling.
Yeah. When you say it throws you, what does that feel like in your body? And then how does that come across to like your spouse?
Yeah, I've discussed with my husband, we call it when I'm spiraling. So that's our fun phrase for it, where I used to shut down and just go quiet. But fortunately, many, many years of marriage, we've gotten to a point where we can communicate and I can say, hey, I'm having a hard time. I'm spiraling. Can you sit here near me, but give me 20 minutes to form the words to say what's going on. And then I want to bring you in and I want to tell you what's upsetting me. And I want to have you throw some logic at me and help me not be so emotional about this situation. Does that answer?
It definitely answers. It makes me wonder about kind of the question around does emotion need to be removed for you to be able to process through something? Like, do those things need to be separate?
True. I think in those moments, I feel like there's so many emotions happening. I'm angry, I'm confused, I'm sad, I'm scared. Mostly scared is probably the biggest emotion that's happening there. Is just so much fear that I'm failing to see the big picture, that I'm just getting into, this is scary and I don't know where to go from here. So I do use my husband as the person who's not experiencing it to kind of pull me back out.
Yeah. Thinking about how your family kind of navigated hard situations, and then how you kind of, it's the pulling back and the need to kind of build like some distance between you and the hard thing that's happening, perhaps for you, so you can look at it clearer. We don't know why they did it, but maybe that's could have been in an alternative world where we can decide how other people manage their own stuff, but just in thinking about kind of those parallels of being removed from emotion when very emotional things are happening can take time. When you feel like you're spiraling, what practices do you engage in that help kind of calm that spiral?
Breathing and a lot of the same techniques that I try to implement when I'm having any other kind of an anxiety attack. It's focusing on sights and sounds, lots of breathing techniques, and kind of counting. I'll usually instruct my kids when they're having a hard time and the emotions feel too big to do a candle breath. And so I'll sometimes use those myself, just kind of get back to basics. Um, just kind of slowing down my brain is usually what I use to come out of the spiral.
Mm-hmm. Yeah. I think that's, those are all so good, great tools.
Mm-hmm.
And again, it's each of those kind of are very controllable things, right?
Mm-hmm.
Like you are grabbing little bits of control where you can
Yeah.
when a situation feels really out of control. So it's a really good like balancing that you're doing so you can get to a baseline of now I can talk through this, now I can work through this with your partner and the person that you choose to navigate hard things with. So incredible. And it's like the more we know about how we navigate things, I think it's so valuable to us as humans. And like, how do I navigate systems and when we think of like hierarchy of needs, it's okay for control to be high up there, because what's the opposite of control is like lack of safety, right?
Chaos. Yeah, that doesn't feel good.
It does not feel good. And so it's, it's good to kind of zoom out and know like it's okay to need a little bit of control and to know where you can find that, because the world is uncontrollable and loss is just so. Yeah. Well, I want to move a little bit into our kind of social area, because when we're looking at grief and loss, the main thing that gets us through any losses is to have a supportive system in place. And so I want to get a little bit of a better picture. I have the paperwork, but those are boxes that you checked. So I want to add a little bit of color to these boxes as well. Can you tell me a little bit about your spiritual or religious background?
I've never really been religious. When I was a teenager, my parents encouraged that I go explore some other religions, go see like what fit for me, and never quite found a good fit. So I guess you'd call me agnostic is probably the best descriptor.
Yeah. And from your family, are they agnostic as well? Did it kind of trickle down?
Yeah, my parents are. My husband's mom is probably the closest thing to a religious, but that extends as far as wearing a cross, and that's about it. So.
I hear that. Okay, well, when we're kind of looking at where do we find social connectedness, it's so important as humans, but very specifically within grief, social connectedness. So I want to kind of dig in a little bit to Jenny's daily routine to kind of see where are you finding that social connectedness if you are. So can you tell me a little bit about a typical day? What do you do? Who do you see? How do you engage with people outside of Jenny?
Well, I am a working from home, stay at home mom. I'm a contractor for a nonprofit, and I only do that about 10 hours a week. But other than that, I stay at home, so I kind of maintain the home, and I'm available for my kids, whatever might be happening before or after school, because they are school age. So that adds a lot of flexibility to my life, but it's also sometimes a little isolating because I don't leave the home to go to work. A lot of my work is more related to spreadsheets than video meetings or anything. So I don't see a ton of people aside from the grocery store or my husband. So.
And for some people, that's very energizing or comfortable. For some people, that doesn't feel good. So if you were to like put it on a scale of like worst fit to best fit for you and your personality, where would your current amount of socializing fall?
I'm usually an introvert, so mostly I'm pretty happy about this. Enjoy just watching movies on the couch in the evening. That's a good time for me. But sometimes I need that social interaction. So sometimes I need a girls trip. That's really recharging for me. So I am probably lacking in that little more than I'd like.
Yeah. Aren't we all? When you said that you want to be available before and after school, does that typically dip you into social communities at all?
Not too much. I don't really get along with a lot of the kids at my parents at my kids' school. Um, we're just not very similar people. I've tried to talk with them, but it's just we're not really vibing. So that's harder.
Yeah, that can be a barrier for sure if you don't like them. They're not your
Yeah,
community, right?
yeah. They're just they're my kids' friends, parents, and that's kind of it.
Yeah. Yeah, and sometimes it's nice for people to fit into very specific categories,
Hmm.
because then we know how to navigate with them and we know who they are to us and who they aren't to us. So
Yeah.
it sometimes having people in those very specific categories can help to not have like you're everything to me,
Hmm.
right? Or maybe you could be. Um so then kind of like looking at who are your people. Tell
Hmm.
me who, like if you had to define three people who are your go-tos.
Okay. Number one is my husband, 100%. And then my sister, she's probably my best friend. We talk almost every day. And then my best friend from college. We talk almost every week, more if possible.
Yeah.
Yeah.
Well, I
I
think
do
it's
have people, but
mhm.
not, I'd like more somehow. I'm not
Yeah,
sure where to find that though.
more but meaningfully
Of course. Yeah.
and not bending, your personality or your beliefs.
Sure. I'm looking for quality over quantity, 100%.
Yeah, absolutely. I think it's a huge benefit to be able to name three people off the top of your head. So you do want to just recognize that that is semi rare.
Okay.
So powerful. I want to ask you a little bit about your relationship with your husband because I would imagine that is the closest
Mm.
one that you have. So tell me about kind of the supportive relationship that you all have.
Well, we've been married for 10 years, together for going on 14. Um, I mean, I do have two other best friends, but like he is kind of that best friend, everything else. He's the
Mhm.
first person I talk to about everything, um, to just like the nauseating details. Like, yep, you know everything about me, and I'm happy that you know everything about me, and I know as much as possible about you. He's that person that I want to share life with, so I'm happy with him.
Yeah. Yeah. I think what's so amazing is when you pick somebody that meets those needs
Yeah,
for you
yeah.
and that you don't.
I got really lucky finding him. He's a good one.
Yes. Yes. Well, that's always good to hear.
Mhm.
That's such a powerful connection because they're your every single day
Yeah.
support. And also coming along with you
Mhm.
on your kind of grief journey that you're going through.
Yeah, he gets to live all of the stuff with me. Like I've said, he kind of helps me process when I'm spiraling or dealing with something. He kind of gets to be that person. And very fortunately, he wants to be that
Mhm.
person with me. So that's huge.
Yeah, that is huge. It's huge. Um, so really when we're kind of looking at the story, the picture that we've created today, it sounds like you have a very solid understanding of yourself. And you also have some pretty solid social supports
Mhm.
that help you, like when you fall out of that alignment with the assuredness
Mhm.
of yourself that you work to build. You have people to connect with. And so, what's really fabulous is in the midst of great grief and life changes that you're experiencing right now, you have a very solid foundation. And so, really, in looking at that, and as we build your treatment plan, much of the work of building is there. So now it's looking like how do we cultivate
Mhm.
those and make sure that we're clicking things in the right spot to make sure that you are feeling supported during a time of a lot of change for you that's making you uncomfortable.
Okay.
Okay. Well, I hope that was helpful. As you can probably tell, that was a highly abridged interview for a biopsychosocial assessment. But I did just want to give you a picture of kind of how we open it up, how we transition through questions, and how we inform throughout the entire process. And so now we are going to have a little documentation demo on that session with October. Thanks for joining us, October.
Well, Kaylee, thank you so much for that presentation. That was absolutely fantastic. I do want to show how the biopsychosocial is done in Iconotes. So if I go into all charts, I will see Jenny's chart here. And if I go to the complete evaluation, which is it's termed that just like the biopsychosocial, I go in here, and as you can see, Jenny has already gone onto the portal and created a biopsychosocial questionnaire for us. All right, it goes through her history of present illness, past psych history. It actually goes through the medical history, like she says, is she taking any medications? She names the medication and the dose there. Her social history is here as well. And so all of this is here, even developmental history and family history. And so what we're going to do at that point is we are going to import this in and create the complete evaluation, because Jenny's already gone in and done a lot of the work as far as documentation for us. So I'll go ahead and click that I want to import that in. It will open up the biopsychosocial, and you can see that right there it says her chief complaint is, I'm struggling with my sense of self, and it lists all the things that are going on with her and all her following symptoms. Now, one thing that we really focused on was grief, and so I'm going to go in and talk about how the client has symptoms of, and we have an array of shrubs here in Iconotes, but I'm going to go to the grief shrub. I'll click on that, and I'm going to say that the information was received from Jenny, right? And that the precipitant for this is whatever is going on with that particular patient. It could be a death of a loved one, loss of a pet, friendship, romantic relationship. We'll say death of a loved one. And then the symptoms of that grief. And so there are going to be emotional symptoms, and we'll talk about those. One is going to be anxiety that she was dealing with. She also had fear, and she had isolation, and she felt some kind of loss of control during that biopsychosocial interview. Now, some of the physical symptoms that she was having is headaches and fatigue, so I can document those. And then she had some behavioral symptoms, and that was the social withdrawal, right? The introversion and kind of isolation that we're seeing. And it definitely interferes with her function. And whatever is going on, it could be that socially, of course, it could be maritally, education. And then you could also rate as the clinician the severity and complexity if you wanted to do that, like low, moderate, high. If you didn't want to do that, you don't have to include that in your biopsychosocial. Now, if I roll into past psychiatric history, she has already been put her information in here. She's seeing a doctor for anxiety, and she doesn't have inpatient history, and she has put in about the Zoloft. And so that is all there for her. And then she also reports the following emotional behavior issues. It's right in the note there. Now, if you were dealing with someone who is currently on psychiatric medication, and if you could address if they're medication compliant, like if there's no history of noncompliance or there is a history of noncompliance, you even have the ability to go in and talk about suicidal, self-injurious behavior, assaultive behavior, substance use, withdrawal, all of those things in the past psychiatric history. Now, with Jenny, I'm going to move on to medical history. She really didn't have a lot as far as medical conditions, and a lot of times you will talk with patients and maybe they don't have any negative or their medical history is negative, so I can click negative and that will give me a nice negative there. Okay. And then on the left side, you see that if they do have any type of medical history, we can definitely document that right here, whether it's from dental to pain to surgical history to reproductive. We have all of that here. Now I can move on to the social history. And she put a really, really nice social history in here. right? So she doesn't have any legal problems. She's never served in the military. She doesn't really engage in hobbies, she said. But one of the things she did say, and I do want to say that you can add a lot of things in here. We're going to do that for her because she did say that she used some coping diversions. So I want to go in and say, as far as her coping diversions, one thing she talked about was watching a movie. And so she likes movies, so we can put that in as she watches movies. And she also, as far as relationship, if they didn't list that in the history, you can go in and really drill down on relationship or marriage, and how many times they've been married, if divorce or separation is happening or occurring, what's their current relationship length, what is their current relationship quality, and say good with a supportive partner. So things like that. You can also talk about employment. She was employed part-time at the nonprofit. So I can go into employment history and I can really say like she works part-time. I can even drill down to how many days a week that she's working. And then developmental history she filled out. We do have an extensive pregnancy history and developmental history in ICA notes, and so I'm able to definitely address that. As far as developmental history, it really drills down to even like words and phrases and toilet training and dressing and walking, so you can get a really significant good history there. And then I'm going to move over to family medical history. Now, Jenny answered these questions for us, but a lot of times you have patients that will come in and say, I think that my mother was thought to have, mood swings or even bipolar disorder. So, and my sister has been hospitalized for depression. So things like that you can enter into the medical history, or excuse me, the psychiatric family history. But a lot of times patients don't know. And so they'll say, I just don't know. And we have a nice negative statement there as far as that as well. But Jenny already kind of reported the ADHD there. And then I can go into the mental status exam. Now, we include all of the elements of the mental status exam in ICA notes, but one of the things we have is sometimes you have folks coming in just to see you again, like and their visits, they're coming back in, and their mental status exams are normal, right? As they come in to see you and you've helped them progress in their therapy. And I can go ahead and click normal, and it gives me a nice normal mental status exam. It puts Jenny's name in it. It puts her pronouns in it. And this is very much tailored to Jenny, but I didn't have to do a lot of typing for this. Right? Now I can go to finish initial. I'm able to put in my diagnosis. So you can do that by looking at it for code. You can ICD-10 by code. So if I wanted to put in like F44.1, I could put that in. I could drill down and look at the ICD-10 diagnoses. So I could go down into my F codes, and then I could pick the different types of codes here. So mood, anxiety, I could pick from here and go in, and I could say, then as she has, you could pick hoarding disorder, post-traumatic stress disorder, social phobia, any of these things. All of the F codes are in ICA notes. And we also have the DSM-5 by code. So if I can put in my DSM-5 code, and then it will then take that DSM-5 and turn it into an ICD-10 code if there's a relatable code for that. So I'm going to pick arachnoid phobia for Jenny. And that's done. I can also put in service codes. Another thing that you can do is you can justify level of care. This is really helpful, especially if you need additional sessions. So I can go in and say, I want to justify level of care. Outpatient is still needed because it's interfering with Jenny's day-to-day activities, and she's unable to self-alleviate those symptoms on her own. And so I'm able to put all those things, especially instructions and recommendations. I can create what we call custom buttons. And so I'm able to create these instructions or buttons and, say maybe there's weekly follow-up with Jenny. Okay. Now, one of the wonderful things about custom buttons is once I create them in one chart, they're in everybody's chart. And so I can come in here and say, I'll put Jenny's name. So I'll say name will attend weekly therapy sessions. and then I can save that. And this custom button, again, will be in everybody's chart. It will be in Jenny's chart. If I go to Fred's chart, it's going to be in Fred's chart. If I go to Jessica's chart, it's going to be there. And then when I click the button, it's going to say, of course, Jenny will attend weekly therapy sessions. But if I'm in Fred's chart, it will say Fred will attend weekly therapy sessions. We have custom buttons all throughout Notes, and you can really tailor the buttons to exactly what you want. And we have these great content modes. So if I like current school functioning, if there was something that I didn't want, like I didn't ask about literacy, hopefully you do, but if I didn't, I could just remove that. Or if literacy was really important, and that was one of the first questions I want to ask, I can move that to the very top there, and it would be there. So the custom buttons, again, are completely customizable to you. Now I'm going back to my finish initial. I'm just going to compile and preview this note. And in just a minute, I'm going to be able to look at the note in its entirety. And here is the note that we created. Jenny helped by putting that information in the portal. And then I also added information, her symptoms there. And scrolling down through that, I have a really robust note. This is a great note. Mental status stam is there, that level of care justification, the instruction of recommendations are there. So we really have 4 pages, and I electronically sign that. So Notes makes your documentation very fast, very efficient, and most clinicians absolutely love it. And so we hope you do too. And so that's my presentation on the biopsychosocial. And thank you so much for attending today. All right. Well, again, I just want to thank everybody for attending today. And I want to thank Kaylee for giving a fantastic interview there on the biopsychosocial. I think her insights were really, truly valuable. And I appreciate her expertise. And just a heartfelt thank you to everyone who joined us to learn more about biopsychosocial assessments. And I just want to say, everyone here, we've got a great array of mental health professionals. And I just want to give a heartfelt thank you to you, because your dedication to mental health is so deeply appreciated. We're grateful for the work you do every day to support and uplift our communities. So thank you, thank you. And if you're interested in Notes, an easier way to document, we'd be happy to connect with you. Please feel free to reach out. We have a free trial. And for our classic users that are in here, we are in the process of transitioning customers over to the Notes Plus program. So it already has about, I know for sure 1,500 users. I think it's closer to 2,000. So if you have any questions about the transition, we are absolutely happy to assist. So thank you so much. So appreciate you guys. And I hope you have an absolute wonderful Thursday. Okay. Take care. Thank you.